I'm going to use the stairs because I believe that's what they're there for. The last thing I'm going to do is jump up. Good morning, everyone. First of all, I'd like to say thank you to the Quality Forum for inviting me here to speak on behalf of Patient Voice and also patient innovation. This is not strictly true. I do need to disclose that I'm a type 1 diabetic, and also I'm quite passionate regarding technology, and I get really grumpy and upset when both of them don't work together. Other than that, nothing much more for me to disclose there. On the screen right now, you can see my real-time blood glucose levels. Every 5 minutes, a new reading will appear on that screen, and that is my blood glucose level. This is the result of eating too much for breakfast, having about 3 coffees, being severely jet-lagged, and about to present in front of 1,000 people. My job as a type 1 diabetic, 7 hours a day, 7 days a week, constantly with no rest, no break, is to keep the dots that you're seeing on that screen within a very tight control range. Now, I'm quite lucky. As a diabetic, I do have access to some pretty good technology to help me achieve that. I have my insulin pump. This is provided for me by the NHS, my Roche combo. It's a fantastic device. It's a significant improvement over multiple days injections. This allows me, hour by hour, to have a finely tuned profile of insulin to be delivered to me that I set up, my background basal. It also allows me to, when I do stuff my face full of too much food, to give shots of insulin, boluses. And again, it gives me lots of different options on how I can actually do that and achieve it. This device gives me a lot of flexibility and options on how to deliver my medication. Also, I'm very lucky that I have a continuous glucose monitor, a CGM. I have a device that I wear on my arm just here that reads my blood sugars every 5 minutes. And that's sent to a device that displays it to me. Every 5 minutes, I get a reading of my blood sugars. This is a significant improvement over piercing my finger, drawing blood, and testing my blood sugars, something that you'd maybe do just a few times a day. Now I have that information every 5 minutes. I can see my blood sugars rise, I can see them fall, I can see what they've done in the past. It gives me significantly more insight and information into the management of my condition. So I'm very fortunate. I have some pretty good technology and quite a lot of data about my condition. Unfortunately, all these systems have a common weakness. There's one area that they're constantly dependent on that always lets me down. And that's me. Because you see, no one seemed to realize that I had a thing called a life. And that was significantly more interesting and more important most of the time to me than the constant monitoring and checking and managing and adjusting of the treatments for the management of my type 1 diabetes. So I do have a fantastic insulin pump. But of all the functionality it gives me, I set this up about 8 years ago, and I've not really changed it since. Out of all the options it has, in reality, I use about 2, because I don't have the time to constantly check and think and calculate and work out what adjustments and changes that I need. This gives me a lot of flexibility and options, but it also makes it much more complicated for me to manage my condition. And in reality, I just don't have the time. My CGM, real-time data on a device that I have no extra pockets in my jeans for. So where does this go? Well, it actually goes in my bag, it goes in my jacket, and it's real-time data that I don't see in real time. And what happens when my blood sugars go too high or too low? Well, the device screams at me. It shouts at me. It alerts. It alarms. It tells me that I've been a bad diabetic and I've messed it up again. And this is a frustration in the diabetic community. We are overwhelmed and overloaded with information. And as more technology comes out and we progress and we get more and more devices and more information, there's always the common weakness that they rely on me. Because what we have is reactive, not proactive use of our devices and technology. And what happens when a patient gets overwhelmed and overloaded? Well, they do the only thing they can. They switch off. And they forget about that condition. Now, the other week, I was on a conference call. I'm on a board. I represent a patient for a new product that's being developed for the management of type 1 diabetes, a mobile phone app. The UK university, once a year we all get together, they present what they've done, and we give feedback. And they've done a really interesting feature, quite clever. They've implemented predictive CGM alarms. They can tell, with quite a clever algorithm, what's going to happen in 30 minutes and send me an alarm. Pretty cool stuff, you know? Sounds great. But has anyone actually spoken to the patient about that? Because actually, I'm struggling to deal with the alarms I'm getting right now. I don't really need the Terminator of CGM alarms traveling back in 30 minutes from the future to tell me, not only have you messed it up now, you've cocked it up 30 minutes into the future, you idiot. How's that going to help me? Because we're reacting to that alarm. It's a reaction of something that's going to happen. If only that alarm told me I was going to mess it up, but then told me what to do to prevent it from happening. Then I have something I can action, something actionable, something that's going to help me, something that is proactive and not reactive. Same data, same technology, we're just treating it in a different way. Now, this is a very common frustration in the type 1 diabetic community. We get quite angry. We're always told we'll be cured in 5 years, and that's been going on for 25 years for me now. We have access we have technology and lots of data that we just can't access how we want to use it, let alone costs. So over the last few years, with the use of social media, the community's been coming together and venting their frustration. But also, they have been discussing ideas. And in 2013, a catchphrase was coined by this community, the hashtag of "We are not waiting." Because as patients, we were sick and tired of waiting to be told what we can and can't do with our devices, waiting to have access to what we want to help us manage our condition, and waiting to be able to afford that technology and to innovate with it. So the patients decided, we are not going to wait any longer. And around this time, we started to see some interesting projects come up from this community. And they all grabbed this hashtag of "We are not waiting." And one of them is a system called Night Scout. And that's a system that you saw on the screen earlier that showed my CGM readings in real time. Now, this is not any kind of new invention or any large business that has done a fantastic new discovery. There's nothing too clever happening here. This was put together by a group of parents who had type 1 diabetic children, and they wanted a way to remotely monitor their children. And they discovered that by taking the receiver for the CGM and a mobile phone, they could connect them together with a cable. And the phone could pretend to be a computer and download those readings every few minutes. And the result of that is that we've put the data into the control of the patients. And what did those patients do with that? They put it onto a website that can be accessed anywhere in the world, so they could remotely monitor their children and loved ones. The important thing to note about this is the fact the work that these people did, they published it open source, what meant it was freely available for anyone to scrutinize, for anyone to utilize, and for anyone to innovate on top of. It was freely available for everyone. And the result of that is that people did innovate. They built on top. One of the frustrations that the community had with that device was the cable between the phone and the receiver wasn't very reliable. Also, some people just wanted that data on their phone. And someone in the community discovered that they could build a small device, a device they called an Xtrip. This is about $50 worth of hobby electronic circuitry, pretty cheap. And what it does, it listens out for the signal from the transmitter that I wear on my arm. When it picks that signal up, it relays it to my mobile phone via Bluetooth. Again, putting that data into the control of the patient so they can do what they wish with it. And this did a few really interesting things. First of all, we got rid of the issue with the phone and the receiver and that unreliable cable. That went. But it also meant that as a patient, I did not have to buy this anymore. So my access to this technology got significantly cheaper. So cheaper, in fact, it was affordable for me to build a few of these and have spare ones, therefore reducing the stress. And again, when the patients had control of data under their own terms, they innovate on top of that. And they moved it onto the smartwatch. Now, I could stop here with examples of projects from the patient innovation side, because what we've done here, we've taken the exact same technology and data that we had before, the transmitter that I wear that picks up my blood sugars every 5 minutes, and rather than sending it to a receiver that sits in my bag, we now put it on my smartwatch. I now have access to real-time data that I can see in real time. Therefore, I can be in meetings, I can be in presentations, and I can always look really impatient by looking at my watch, but I know what my blood sugars are really quick and easily. And that is significant change to mine and others' lifestyle. We now had easy access to that data that we could easily be accessible for us just on our wrists. Okay, I go to a lot of meetings, people think I'm in a rush, they think I need to get a train or on board, because I'm constantly looking at my watch. And the sheer number of times I've actually looked at my watch to get the time, and I've come back with my blood sugar readings. But anyway, it's very useful. But it wasn't just in the CGM area, the blood glucose area, that this innovation was happening. Some of the patients discovered they could get information from a particular insulin pump. They could get the information of the insulin that they've consumed and taken, but also they could control the pump. So all of a sudden, we had the information that that community, the patients were already capturing. We already have to track our blood sugars. We already have to use our insulin pumps if we're lucky enough to have them. We already have to log our foods and check it. But now we're doing it all in one place. We have all that data stored on a device under our control that we can do what we want with it. And what did that community do? Well, they innovated, and they developed an artificial pancreas system. Now, no one at the beginning of this movement said, you know what, I'm going to build an artificial pancreas because I get laughed off the stage. And that's absolutely crazy. How on earth are you going to build an artificial pancreas? But with the community working on individual issues, with them working together and sharing that between each other, small steps were made. Until we got to a point as a community and we discovered, actually, with quite a simple algorithm, we can predict now with this information where the blood sugars are going to change and go, and if need be, we can control the pump to help prevent that. Therefore, an artificial pancreas. Now, this happened around about 3 years ago. This came onto the scene. I saw this and thought, whoa, that's pretty damn cool. Look at that. The problem is, though, the team in America who were working on this, they were wearing a fanny pack to all this stuff in there, and that's not cool in London. I'm not going to walk down the street with a fanny pack. I don't care what it does to help me manage my condition. So I was like, this is good, but it's got to change. So I went out there. I took the code that community had produced. I took the bits I liked. I spoke to people. I worked with people, and I developed a mobile phone app. Now, this doesn't talk to my insulin pump at the time because my pump's not supported. But the way this operated was a thing called an open loop system that we call. In other words, every 15 minutes, it takes all that information that's been automatically collected about myself, or that I have to collect anyway, it crunches those numbers, and it sends a notification to my smartwatch. and tells me if I need to adjust my insulin pump to help me prevent high or low blood sugar levels. And this is significant. For the first time ever in my life, I've gone from having to manage my devices and data, constantly check and guess and try and work out what to do, to the same devices and the same data now working for me. They were now telling me what to do to help me prevent my blood sugars going high and low. We're not curing diabetes, but we're using our existing technology and data now to work for us. We're being proactive with those devices and that data. Now, I can tell you, there's a lot of arguments at the beginning. It told me to do this. I said, you're bloody crazy. I'm not doing it. And then later on, it would prove me wrong. So there was a trust issue to start off with, but over time, I got to trust the system. Now, the other week, it was a busy week the other week. A lot of things happened. And one of them is an event that happened in that community is quite significant for me. And 3 years ago, I announced that I wanted to hack my insulin pump. See, my insulin pump is a great example of something that has been design limited. It's not technically limited. My insulin pump has Bluetooth. My mobile phone has Bluetooth. Great. We connect them together, I got all my data, and I can control my pump. No. The system designed not to allow that. And the other week, a team of very talented developers have now made that happen. But the journey to get here, over those 3 years, reads like something out of a Hollywood blockbuster. We had despair. We had the patient frustrated that they couldn't use their device and their data the way they wanted to use it. But they had a desire to make it happen. We had mystery. I had an email appear in my inbox one day with some very interesting information that could enable us to do this. And then the individual who sent it just vanished. We then had suspense. We had secret online conversations about what we've got our hands on, discussing what should we do? Should we do it? What's going to happen? Is someone watching us? We then had horror. Is one of us an insider? Do we even know who each other are? Can we trust each other? And this actually happened. I'm not even joking. And then we had ransom. Someone had a secret key that we needed to link the two devices together. And they wanted a significant sum of money for us to get it. But in the end, as with most Hollywood stories, we had a happy ending. We had a group of people who came together, who worked very hard, who managed to make it happen. And they published it for free for anyone to utilize. All of that over 3 years, just so I can use my insulin pump and the data it contains the way I want to use it to manage my condition. Now, I spoke to some of the developers the other day, and we've done some rough estimates. And we believe over those 3 years, it took 10 developers, 10 very talented people, in their spare time, collectively over 5,000 hours worth of work to make this happen. And as one of the developers said to me, I spent way too many nights working on this project. Now, just imagine what we could have done with 5,000 hours of talented individuals innovating, working with that data on the pump, helping us to help us better manage our conditions, rather than waste 5,000 hours on trying to work around the restrictions that have been applied on us to prevent us from managing our condition the way we wish to. And this is one of the frustrations that we have in this community. It is really limited to the most technical. It is limited to only the 1%.
Hey, Tim.
Yes?
Sorry. I'm really sorry to interrupt, but I don't really agree with your statement.
Okay, well, please feel free to come and join me on the stage and explain why.
random person in the audience. I'm really sorry to interrupt your plenary speech, but I just want this audience to know, a really smart audience, that this isn't just limited to health hackers like yourself. Right here, right now, I am connected to an open app system, similar to what Tim's talking about, that's acting like a DIY closed loop artificial pancreas, which I think is pretty darn cool.
Well, that's pretty impressive, but quite clearly you have to be a technical genius to do this, you know? Like.
Sadly, no. But I have zero tech capabilities. But what I do have is an extensive We Are Not Waiting community around the world. You're a great example. Who about 8 months ago helped my friend and I set up our own system. And it was so easy. And I mean, I'm someone who struggles to set up IKEA furniture. And I did this. And it was so easy. So if I can do it, anybody can.
Well, that is clearly very impressive. And how has it helped you?
So I've been type 1 diabetic for about 15 years now. And as Tim said before, life makes you a really bad diabetic. And in the last 15 years, through school and work and life, your blood sugars are never always stable. But for the first time, my average blood sugar, my hemoglobin A1C, is so consistent and so in target that for all you physicians out there, if I took a blood test today, you wouldn't know I was diabetic. And I think that speaks to the power of this system, the ability to sleep at night, to not worry that in the middle of the night, I'm gonna go low and not wake up. And it's just this weight has been lifted off of my shoulders, and I can live life. Life's crazy, life's fun, but high blood sugars, low blood sugars really put a damper on that. And so it's through the work of health hackers like Tim and the We Are Not Waiting community that really gives a voice to this people and patient-powered improvement.
Thank you, Kerry. Yeah. Kerry contacted me about 3 months ago when she heard I'd be presenting today, and she shared her story with me. And I would like to say thank you as well for allowing me to drag you on the stage.
Yeah, I just Facebook messaged him to wish him luck. And here I
And also to help me with questions towards the end, because this is a worldwide community, as Kerry said. We have both achieved something that we would never have done on our own, and it's with the help of others who have done this. First time we met each other was yesterday afternoon, but we both in life have a common desire and a common goal. Because you see, we don't have a budget we need to hit. We don't have stakeholders to look after. We don't have tick boxes to tick or statistics to meet. The only thing we have as patients is that the desire to better manage our condition, to use what we have in a better way, and to share that and to help other people do the same. Because this is people-powered innovation, and you are the people. It's people like you who are working on this. It's people who are sitting next to you, literally like Harry, who are doing this, and they are making it happen. Because we are not waiting. Thank you.
Well, thank you both. That was a phenomenal introduction, and it raises a zillion questions. So, are these questions also coming up? Yes, no? Yeah? Should be? Right, all right. So, can you see these? Mm-hmm. So, what I'm going to do is, in the spirit of allowing you to control your own destiny, why don't you pick the one you want to address first?
Should we go? Yeah.
Yeah, come over here. And
Could I do the cyborg one, actually? Because that actually does make... And it's got 0 votes, but anyway.
Yes,
Well, I definitely agree. And I broke my leg, snapped my fibula, actually, a couple of years ago. And so I got a metal rod in my leg as well. So I feel like a really rubbish Robocop. It is quite funny. But very quickly, no alarms do not go off at the airport. Yes, Hollywood make our devices look like they're something dangerous. They're not. They're as dangerous as a calculator. And yes, when your battery runs out of power, it's a lot more important.
So let me ask a question about the journey you went on and why it took the 5,000 hours in this kind of underground or parallel community. Are the barriers commercial, that people want to monetize this, or is it a well-intentioned but misguided paternalism? You know, you shouldn't have this control because you won't know what to do with it, with your data, et cetera, et cetera. What went on contextually in this journey?
So it is interesting because myself and Carol probably have different answers to this, and this is one of the interesting things of that movement. You know, we work together, but we are all as well independent. We do live in a society where making money is a good thing, unfortunately, to a certain degree, and there are a lot of costs that have to go into research, et cetera, to produce the goods. So one of the things I don't want to tarnish is the industry as being bad. But one of the frustrations that I personally have is that I'm constantly told I need to get my new insulin pump. Because you know why? It's 3 millimeters thinner, it has a different color, and it has a touchscreen. I don't care. This works. It works well. So why don't we focus our energy in making this more affordable and accessible? If we focus our energy on that, more people will benefit. This is not an iPhone. This is a device that keeps me alive. So I think as a society or as an industry, we're obsessed with having the latest and greatest, where actually technology, this is about 15 years old, does a pretty good damn job.
And as you can see, a number of the questions were about your relationships with your physician. And this is obviously taking control, being empowered, one of the hallmarks of patient-centered care that we keep hearing about. But does it alter the relationship? And if it does it alter it for the better? Are your physicians supportive? Do they get it? Do they say, yes, this is exactly what we want you to do. I should be less involved. You should be in control, et cetera, et cetera. How's that gone?
What does your endocrinologist say? Mine loves it.
I'll let you go first.
Mine at first didn't believe me. One of those patients that I like to go in with my list and tell him this is what we should do, and he usually agrees. But for this, he was a little hesitant, especially because right now I'm wearing an out-of-warranty pump only because it's hackable, and so that carries its own risk. And I think as a physician, that scares people, but the benefits within 3-4 months of wearing this, they can't say no. There's no other option out there.
For me personally, unfortunately, my experience is a little bit different. 10 years ago, I gave up on the hospital ever telling me anything I needed to know. Because with diabetes, you've got no choice but to become an expert. My support circle is social media, to be honest. But I have spoken to many professionals about the work, and it's a classic 50-50. They have the excitement of patient innovation and power. You know, a patient suddenly feels empowered. You know, forget about if it works or not. The patient's happy and they're empowered. Is that not good enough? You know, it's a great thing to see a patient take ownership and control. And then the other half of them is freaking out. Oh my God, they're taking control. Oh my God, they're doing stuff that could potentially be dangerous. And one of my kind of opinions on that to leave with people is the fact of don't focus on the fact that we're using potentially out-of-warranty pumps. Don't focus on the fact that we're doing something that you class as potentially dangerous. Focus on the question of why are we having to do it? Why do we need to use devices that are out of warranty? Why are we having to innovate on our own to do something to help us? And why is it working? And these presentations, the talks, are my opportunity to spread those conversations. Let's not just say it's a bad thing. Let's just ask why. Why are we not using this really talented, wide community of experts who are very good at managing that condition and sharing that? Why are we not utilizing them somehow? Why do we have no care path that utilizes this? Why do we not involve them more, or listen to them, or empower them more?
In your talk, you sort of alluded to the possibility of too much data. Like, this is constant. You're always aware. You can't not know. You have no excuse anymore for not knowing, right? So this is both a blessing in the sense of it allows you to take control and do what you need to do, but some could say it's also a bit of a burden, that you're constantly, it's like people who are driven by their Fitbits. I hope that's none of you. So is that an issue? I mean, does it create the possibility of so much real-time data on, and we'll ask in the follow-up, because one person asked here about other conditions, is there a balance to be struck there? And I mean, you referred to it that now you get less and it's better. What's your experience with that?
Well, we're on two slightly different systems. So Tim's is open loop. And correct me if I'm wrong if I explain this not so well. So he makes changes based on what your software recommends. So he's taking a lot of data in, but it's making it fairly easy to make those changes. Whereas my system is a closed loop system. Almost closed loop. I still have to input carbohydrates, but it will predict fitness. It will predict my blood sugar after working out. It will know if I'm eating something, how long it's going to take for the food to digest. It calculates that all in an algorithm, and it makes changes to my pump automatically. So right now, like I feel my pump vibrating, and so it's making changes, probably because I'm spiking like you right now. And it makes those changes with that data, so I'm almost just a backseat driver. So for me, that data is not overwhelming because it's doing it for me.
So with most, so there's a very common issue that I come across is with people who have CGMs, the device that gives you the real-time readings, and it's so difficult to get one. Impossible in the NHS. It's extremely expensive to run, but don't worry, we've cheated the system somewhat, and you can talk to me afterwards if you want to know what we did. So to actually have one and to be able to afford and use it is quite a rarity, actually. But I know so many people who stop using it. And I'm like, wow, like, this is like the best thing ever. Why would you stop using it? And they say, because all it does is alarm. They don't say it's because my sugars are high or low or I'm struggling to manage. I don't like it because it just alarms at me all the time. And the work that the community are doing, we're taking the exact same devices, the exact same data, but we're making it actionable. We're being proactive with it. So as Kerry said, her system's automated. It automatically does that adjustment. She literally does forget about her diabetes. For me, I get notified on my watch every 15 minutes what to do to help me prevent my highs or lows. So I still have some control, but I get informed. And for some patients, that's what they prefer. The main point is we're making the data work for us, rather than it just constantly yell at us.
Now, again, there's some following on your Hollywood blockbuster, the notion of hackability. Could someone diabolically hack into your data, reprogram your insulin pump, and stick you into a coma in 5 minutes?
Well, are you threatening me? Sorry, I'm sorry. It's recorded, just so you know. Do you mind if I answer that one? So let's be very clear. This is a very serious question that has a very serious answer. What's an answer you can't really do in 30 seconds, but let me kind of try my best. Insulin is a lethal drug. It is highly dangerous. It will kill me if I give myself too much. There's a thing called insulin stacking in diabetes, where you get frustrated and you constantly inject because you can't get your sugars low. And there's nothing telling you how much you've done, how much you've taken, what's a dangerous level. There's no controls over it because it's the patient who's responsible. With the systems we're using, they track it. They tell me. I can look at my watch and go, yep, do you know what? My sugars are high, but I've got 5 units of insulin active right now. Probably best just to leave it. So yes, there's always dangers with systems, but we're utilizing the systems to our advantage to help us better understand and make more informed decisions. And with the automated systems, there's safety mechanisms built in. You know, this is not the first industry to do something with technology. There's a whole world out there using technology and has safety built into it. You know, just the medical industry is far behind. So there is natural safety mechanisms built in. Is there potentially some danger? Yes. I'm diabetic, there's danger.
What do you think about, you're collecting a lot of data, fabulous data, individual level data. It's conceivably of interest to researchers, to health system managers, to get a better handle on a condition, its prevalence, what goes on, et cetera, et cetera. Do you consider your data a public resource, shareable, anonymized, or is that a big ethical issue?
So there's the Night Scout Foundation. That's a not-for-profit that came out of the Night Scout web system, that's CGM data, and they have an opt-in system where patients can submit their data for research, and that is available for free for anyone to look at. I think majority of patients would agree, and Kerry, feel free to correct me as needed. We are more than happy for you to have our data. If you are going to invent something that's going to help me, fair enough, charge me, whatever. If you're going to analyze something to have a better understanding, absolutely fine. If you're going to try and increase my insurance premiums, I'm going to be a bit annoyed. So It's the use of that data that is a sensitive side, not necessarily whether we're happy for it to be used or not. And to be honest, most of us are on Facebook, so we clearly don't care much about our privacy that much. So it's all about how the data is utilized, not necessarily whether it should be used or not.
And the community, the We Are Not Waiting community, is so good when you're trying to troubleshoot. And they will go in and look at your data and offer support at no cost, no gain to them, but because they're part of this community and they believe in what this community is trying to achieve. And I think that's really awesome.
Literally 24/7.
24/7.
It's insane.
Yeah.
Absolutely crazy.
Yeah.
So let's broaden this to the world of public policy. By all accounts, this is a remarkable grassroots, advanced, successful movement. How would you, if the world unfolded as it should, what would happen so that everyone in Canada, or everyone in wherever you happen to be, which country you're in, in whatever week you're in, Tim, that this is generalized? What do you need from a provincial government, or the NHS, or the local health authority, or a primary care network to make this standard fare as opposed to a vanguard movement of rebels?
So the first thing is standardization. And again, look at any industry other than medical, and it's already happening. There's nothing new here. Standardize information, standardize access. You know, this pump holds information about me. Why do I have to fight to get it? You know, there's different levels of potential risk. There's no reason why I should not have complete unrestricted access to my data, that I can do what I want, be it put it in Excel and do pretty charts, do it, analyze it, and build an artificial pancreas. This is my condition, this is my data, I do what I want with it. So stop restricting me. So open access would be the first step, and that is actually happening. There is discussions now about open protocols. But the second side of it is the constant obsession with new technology. What do we do next? What happens next? How do we cure? Well, do you know what? Forget about all that, because it's not about what happens next. It's us trying to deal with it right now. That's what we're struggling with. So let's focus on what we have now, because actually we do have some really good stuff. It's just most people can't afford it, or it's too restricted by design, not by what it can do. So let's innovate with the current technology.
Yeah, I was going to just add to that, especially in BC. Like, this technology is great, but what if you can't afford an insulin pump? What if you're not covered for a continuous glucose monitor? The middleman, the link, doesn't do anything if you don't have the actual technology you need, not only to control your diabetes, but to make this system work. And so that's something that the community is advocating for as well. They're very busy, but...
So just on the cost side, as near as you can tell now, if you had all of the effective but not excessive technology you need to make this work, how much is it on the ballpark per person?
Oh, do you know what? I don't know if I can even be answer that on the spot. It's a challenge. If you take individual components, as with anything in life, and break it down to its elements, you probably discover it's actually pretty damn cheap. Like the Xtrip system itself, you know, this is hobby electronics. This is people build robots out of this sort of stuff and play around at home. We built a medical device. You know, the actual components are not expensive. It's buying it when it's packaged in something that's commercialized is when it gets expensive. So that's kind of where we need to see more innovation and help. And for example, we all have mobile phones. Why am I having to carry a second screen with me? Let's utilize what we have. But there's this constant fear in the medical industry of doing that. And we really need to start progressing. Yes, there's risk. Yes, there's sensible steps we can take. Yes, we need to analyze it. But you know what? If the industry's not going to come with us, if the medical practice is not going to come with us, if the doctors or everyone else is not going to help us, we know what, we're just going to do it ourselves. Because the great thing about technology, it's available for anyone. You know, we all have access to it. We can all use it. We can all lean on each other and share it. So let's start acknowledging that and see what we can do to support these people in a more protected environment. Do you mind if I answer one more quickly on there?
Please.
There's a question regarding other people with different medical conditions. Are they doing a similar movement? I'm definitely no expert on other conditions. Unfortunately, just diabetes. But there is it's a hearing hack community in London who are trying to build the same thing. And they're a community who rely on hearing aids and are completely restricted by the access to technology and the costs to calibrate and actually use those. And they are trying to build their own momentum and community as well, to kind of start standardizing and producing home-built hearing aids using the technology that's in our mobile phones. So yes, other people out there are doing this. This is happening. The great thing about the type 1 diabetes community, it's juvenile diabetes. A lot of people get it young. A lot of people get quite emotional about it. There's a lot of kind of people who are quite technical and able, and it's quite a passionate movement, I think. So we've kind of hit the sweet spot, I think, on that innovation side. So we're quite lucky with that.
How rapidly is your community growing? And at what point does it become an irresistible force?
Quickly?
Yes. Yeah. I get people contact me quite often for discussions. It's got to the point now actually where this weekend, unfortunately I'm going to miss it, but in London, the community are putting on a conference called Rise of the Machines, and they are inviting the clinicians and industry to it. So that's the patients putting on a conference. So the momentum here is really, really kind of moving quick. And I believe the majority of diabetic healthcare professionals in the UK have had someone walk in and go, look what I made. It manages my diabetes. That pretty spreads quite quickly. So yeah, the community is growing quick, and people are getting very aware of it.
And is anyone pushing back? Like, what has been? Do you get an official response? Do you get fear-mongering? Do you get people saying, "Well, wait till you have an adverse event and somebody dies, and then the lawsuits ensue"? And
so this is one of the challenges, and one of the things we'll be very clear about is we're not sitting here saying that we are super clever and we're therefore that much more safe and we know better than everyone else. So we're not trying to say that. What we're trying to say is that we are making better use of that data and technology to help us better manage our condition. And that comes with a significant number of positives with a very low number of negatives.
You don't really have any other options, right?
Well, what do you do? Just not care anymore?
Yeah.
I don't care. I just won't worry about my diabetes.
The little risk versus all the benefits. It's no competition, at least for me. You.
Most definitely, I agree. And we do have people who do literally freak out over it. But once we discuss with them and explain the situation, explain what we're doing, explain how we're capable of doing it, it progresses. But I have had some interesting conversations with industry where I've had people for an hour on the phone with pure excitement about what's happening and then say to me, we're just going to go and talk to our legal team, and then never hear them ever again. So I think there is definitely a situation in the industry where there's a cast a blind eye situation, and that's just not going to last. This is happening, and we need to start talking about it. And it doesn't mean the industry needs to support it, but they need to acknowledge.
So this is, in a sense, a very disruptive technology to the way the world works, right? I mean, normally you have a very large medical devices technology innovation business, go through all the regulatory steps, monetize, first movers make a lot of money, blah, 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 blah. But this is ground up, distributed, democratic, revolutionary kind of stuff, right? So, again, this is a tough question, but if you generalize this to other conditions and it becomes, in a way, a growing new normal, do you see this transforming healthcare in major ways other than in a one disease-specific circumstance that seems to be particularly adaptable to this kind of approach?
Well, I think we do need to acknowledge that the patients are experts, whether they want it or not, to a certain degree. and that as an industry, the healthcare industry is significantly behind. And that's not necessarily the industry's fault itself. You know, there's a lot of red tape, a lot of regulations. You know, we're not used to the progress of technology. And the healthcare system is not designed for that progress, hence why it's so far behind. But as with anything else, you know, if you want to build a drone, for example, you can go to shop and buy one, or you can get some plastic PVC pipes and buy a few components online and build your own one. So the accessibility of knowledge and technology, like, there's no boundaries anymore. You know, the people we work with and chat to are literally global, you know, all over the place. And it just takes one or two people with the right skills to share it with everyone else and discuss it and educate other people for us to then be capable of making things happen. And that's not condition limited. This is the use of technology. And this is happening everywhere. So yes, I think we'll see a lot more of this, and I think we'll see more and more conditions taking advantage of that wider community network and the technology options available.
Yeah, and I just want to add, I mean, we're all here for people-powered improvement. There's an acknowledgement now, more than ever in healthcare, that patients are at the center of their care. They should have been from the very beginning, but now there's an acknowledgement. And so I think because there's a room full of highly intelligent, passionate healthcare professionals in the room, instead of being scared of this, to take that patient-centered care one step further and think about patient-driven care and how you can harness that and actually make significant improvements fast, because we're not waiting.
Mm-hmm. So you know, of course, that especially people in this room, but generally we want evidence-based improvement. This technology should be able to produce some pretty compelling evidence that this will result in fewer complications, better long-term outcomes, because control is the holy grail, right? Mm-hmm. So are you organizing at all to try to harness that outcome data over time so that even resistors or even skeptics might say, hell, that's amazing. Here's a cohort of 5,000 people. Here's 10 years of data. Look at this compared to the norm. It's spectacular. I mean, do you think that's a useful thing to do? Or do you think actually you can bypass that stuff now and just say, look, we're not that interested in doing research for the man here. We're just going to spread this movement because it makes so much sense.
What we do happens because we are able to innovate. We're able to do what we want to do because we are primarily helping ourselves. You know, I'm trying to improve my condition. I'm just sharing that knowledge with others. So, for example, I'm not going to build a system for someone else, but I can educate them why they would want to build a system and how potentially to do it. So the sharing of that knowledge and distributing it, there's a lot of potential opportunity to really take advantage of that. And now I've forgotten your question, to be honest.
Well, just whether or not you think it is important, useful, or irrelevant about the research agenda.
So the Night Scout Foundation is collecting that data and putting it in one place. But also you've got to bear in mind, this is people's spare time. You know, we don't work for a company that will pay us for the hours to make this happen. You know, our focus is improving the quality of our care. Unfortunately, everything comes second to that. So yes, most definitely there's value to validate it, and I'm very keen for people to partner with people, and it has been happening, to validate what they're doing and a positive outcome to it, but also respect for the fact that I struggle to do most of the things I want to do. So to me, to get the capacity and time to do that, it just doesn't exist. And also, another point I want to make on that is, I had a chat with a physician a few years ago, and they said to me, like, where's your evidence data? Where demonstrate this works, demonstrate the outcome, demonstrate. And I said, you know what? Maybe none of it works. But as a patient, I feel like I'm in more control. I feel happier. So if that's the outcome, why does it matter?
Great. There's another question at the bottom, which was, it just flashed off, about do you think a technology like this could help people, for example, who are legally blind?
So that's a very interesting comment, actually, because when I first announced I wanted to hack my pump, I went out to the community and posted on websites, and look, anyone got the skills who can help me achieve this? One of the first people who contacted me was a group of blind diabetics who said that they couldn't use the pump. They had to constantly get help to configure it. And if we could build a mobile app that utilize the disability framework that the operating system on the phone has, they could finally use their pump without help. And it shocked me, because it's never crossed my mind. There'll be people out there who could potentially benefit from that. So yes, most definitely. Unfortunately, that app has not been made yet, again, people lack of time. But yes, most definitely. And also, before the question gets asked, it introduces new risks. But there's ways to manage risk.
And again, you had referred to it earlier about your pump being a little older.
Yes.
So there's a question, what do the pump manufacturers think of this? Are there IP, intellectual property and copyright concerns? Or would they be great partners in this? Do they want to be partners? Do they see this as a threat?
Well, I think from someone who's not techie, all the manufacturing side of things, like, I don't care if they partner. And I don't care what they think about it. The fact is, we hacked their system, and we're making huge strides. But it would be really great if they provided source code to people like Tim, so that they could hack more advanced pumps. I left a pump that did a pretty good job, but it was waterproof and it worked. And I'm on a pretty historic, vintage contraption right now, just so that I can use the system. So it'd be great if they could partner and provide codes.
So I think, as I said earlier, there's when you speak to the industry, their automatic reaction now is generally just to shut down, because the risk of associating himself with a patient who's done this, completely understandable. People are talking about it. Now, the thing I think for us is, right, you could give me complete control of my pump to do whatever I want, or you can just give me easy access to the data. So there's different levels of this, and there's no reason, there's no risk to that patient, but just giving them that bloody information so they can put it where they want. So one of the things, there's easy wins here, and there's really no excuse to start doing them. And I think we just need to start getting people internally with the confidence to actually raise, we need to do this, because if you don't, someone else will, and as soon as that competitor does it, you're going to go, because everyone will switch to that pump.
And I'm just going to ask one more question, because we're running out of time. But we've talked a bit about the role of physicians, and you'd mentioned that your physician loves it and so on. But there's the positive part of this is, what is the best way for physicians to support and / get out of the way of patients being involved? But if you could implore the physician community or the healthcare community generally to get on side with this, what would you have them do?
Acknowledge, to be honest. I think I don't expect docs to take responsibility for it. This is patient-driven. This is patient responsibility. I'm doing this because I decided to. And we're seeing this more and more, especially in the UK, where physicians, they acknowledge it, they listen, and they at times may flag concerns. They may, just that acknowledgement is all that's really required. We do not expect them to come and configure the system for us. That's the patient's responsibility. We're doing this because we want to. So this acknowledgement is what we're after.
Great. And I guess one more final on that, which is, you're a self-described patient-driven ground-level group of rebels, right? Would it make you uncomfortable if this became mainstream and conventional, and that this became kind of part of the system? Would you lose some of your identity as being, damn it, we did this, we took it over?
No, no.
So you're happy.
That's
you're happy for this to be embraced. So you need to get in the policy business then, right? In a sense. Well. Because at some point you need an interface, right? I mean, if you want this to be generalized, if you want this to be baked into the DNA of the system has to be your partner in some way, right? So how does that happen? I don't say you guys have to do it, obviously, but what would you like to see happen so that the province of British Columbia is the world's first jurisdiction that sort of builds this into its diabetic care?
So the interesting fact is the fact, as soon as you try and make it part of the system, then is that not instantly where we then fail, because the system's not capable of supporting such an environment? So I think we really need to start thinking out the box. And again, you don't need the system to support it, just acknowledging it. Maybe arranging for patients to talk to each other. You know, if you're concerned with a patient who wishes to do such a thing, but you feel they don't understand their condition well enough, you need to know how to manage diabetes to do this. This is not going to fix you. This is not a cure. This is something more complicated you can do with a better outcome. So you need to partner with the right people to help you achieve that. And there's nothing more satisfying than sitting down with someone and they look at their watch and they have their blood sugars. And there's nothing more frustrating and sad seeing someone sit there and they can't do that and they wish they could.
What? Okay. Okay. So we've got a plea for one more final question, which is the top one there.
I've not even prepared for the debate, so don't worry about it, to be honest.
Are you on the wrong side of the 1:30 debate?
Oh, no, I'm on the right side. That's why I'm so relaxed about it.
Exactly.
And I'll just sit there and sulk if you
Tim's
try and argue with me. So.
All right. Well, that was an amazing start to our conference. Thank you so much for joining Tim on the stage. Fabulous, tremendous amount to think about. And I think a glimpse of the future and one of the most compelling examples of patient-driven, patient-centered innovation that I've ever heard. So thank you very much both again.
Thank you, Karen.
Okay.